Yes, this was actually the primary pattern of recurrence in patients treated in STOMP or ORIOLE with metastasis-directed therapy to bone metastases. About 86% of patients experienced recurrence in new bone metastases, and they were different sites than the sites that were treated with SBRT or other metastasis-directed therapy, so we believe it's related to microscopic disease in the bone. Yes, Radium-223 was FDA approved in 2013 based on the phase 3 ALSYMCA trial, which was in patients with metastatic castrate-resistant prostate cancer with symptomatic bone metastases. And that trial resulted in improvement in overall survival and in symptomatic skeletal events. So that resulted in FDA approval in 2013. And then more recently, there was also the PEACE trial, PEACE 3, that showed an improvement in overall survival in first-line metastatic castrate-resistant prostate cancer with radium plus enzalutamide versus enzalutamide alone. And that was just presented recently by Dr. Gillison at ESMO in 2024. So the RAVENS study was a phase 2 non-blinded multi-center study. It was in 5 centers and was randomized 1-to-1 to have men with metastatic hormone-sensitive oligometastatic prostate cancer with up to 5 lesions by PET or 3 lesions by conventional, treated either with SBRT alone to all of the visible lesions, or to SBRT with up to 6 cycles of Radium-223. And the primary endpoint was composite progression-free survival, which was including progression by PSA using PCWG2 criteria, or radiologic progression, or initiation of ADT or symptomatic progression. And the composite PFS was not different between the 2 arms. We had 64 men randomized 1-to-1, and the median PFS in the SBRT arm was 11.8 months versus 10.5 months in the combined SBRT plus radium arm. So no difference in composite progression-free survival. Oligometastatic hormone-sensitive prostate cancer can include patients with distant lymph node metastases or bone metastases. Bone metastases are very common in this setting. They are not difficult to treat with MDT technically. It's easy usually to target safely bone lesions in almost any location. But as we mentioned earlier, there's a high rate of recurrence in other bone sites. So while they're technically not difficult to treat with MDT, there is a need for other therapies in these patients. So there's a number of treatment options. These are patients, typically we're talking about metachronous oligoprogressive disease, so patients who previously had a prostate cancer controlled with radiation or surgery, prostatectomy, and then had recurrence with just a few sites of disease. So there are many treatment options available to these patients, including androgen deprivation therapy, androgen receptor pathway inhibitors, and RAVENS is the only randomized study to investigate radium in this patient population. There are some other single-arm studies that have investigated radium, but there are a number of studies currently ongoing that are investigating another radiopharmaceutical strategy of PSMA-directed lutetium-based therapy. So there's the LUNAR trial at UCLA is a phase 2 trial using lutetium PSMA 0.2002. And then there's a phase 3 trial that just began of lutetium PSMA 617, and it's SBRT plus or minus 4 cycles of lutetium PSMA 617, and that's molecularly targeted to the prostate-specific membrane antigen, and it's 4 cycles of the therapy, and it's randomized 2-to-1 to the Pluvicto or lutetium PSMA 617 arm. So there's a number of ongoing studies that will help potentially show the relative benefit of lutetium PSMA targeted agents, and I think we'll have more and more treatment options for this patient population. So we're continuing, we just submitted our article for publication. So that's the immediate next step, and we are continuing correlative analyses. So one of the main outcomes of this study was that we were able to highlight 2 very important biomarkers in this patient population. One is a high-risk genomic signature that was validated as a prognostic marker both in RAVENS and in ORIOLE, and that is including pathogenic mutations in ATM, BRCA1, BRCA2, RB1, or TP53. And the other correlative that we highlighted was T-cell receptor correlatives of unique productive T-cell receptor rearrangements, and showing that a higher number of these rearrangements at day 90 of treatment was prognostic for better PFS and MFS. So that's an area that we will be exploring more as biomarkers in this patient population. We're also investigating other biomarkers as data is still coming in from the other sites for this trial.